I'm working as intensive. Okay, I'm working as intensivist at Apollo Hospital, Mumbai, along with Gunadhar sir and Akhilesh sir. So basically, I welcome all of you on this 44th educational series on platform of Apollo Mumbai Critical Care Learning Network. Today's topic is ultrasound to guide fluid therapy. I welcome Dr. Gunadhar Padi sir. He is a senior intensivist consultant at Apollo Hospital, Navi Mumbai. I welcome Dr. Akhilesh Chandekar, who is senior consultant in critical care medicine. I welcome all speakers and panelists, but I request Dr. Gunadhar sir to introduce our speakers and panelists. Before that, I request all of candidates or anyone who wants to who wants to have any queries or want to ask any question can put in chat box. And from here, I hand over to Dr. Gunadhar sir.
Yeah, thank you, Swapnil. So today is going to be a very interactive and interesting session. And basically, the demand of ultrasound is growing day by day in the critical care. So that is the reason today we have with us, we have invited the eminent speakers, Dr. Adrian Wong. And Dr. Adrian Wong is completed his training in anesthesia and intensive care in 2014. And he is a consultant and clinical lead at King's College Hospital, London. And within the critical care, he has an interest in the use of point of care ultrasound to guide fluid management and especially around venous congestion and organ perfusion. And also he has very much interested in many of the point of care ultrasound for diagnostic and therapeutic purpose. His other research and interest include clinical governance and safety, medical education, and burnout well-being. He is a member of the Intensive Care Society FUSIC Committee. He is an examiner for the European Diploma of Intensive Care Medicine. He was the ex-chair of the Social Media and Digital Content Committee of the ESICM and the course director of the Genius Ultrasound course. He is on the executive committee of the International Fluid Academy also. So with this, I welcome Dr. Adrian Wong, and with him, we'll be having another very eminent panelist, Dr. Segun from Bartholomew Hospital National Health Trust, United Kingdom. And probably he'll be joining us in the question answer session where we'll like to introduce him. And not to further delay, we have all the moderator with us, and let's start the session. Basically, this is a recorded session because Dr. Wong was busy. There is some strike going on, so that is the reason he has sent me this lecture. So this is a 30 minutes lecture and followed by the whatever the questions the panelist has that we're going to address. So can you just tell a few lines to all the intensivists right now who have joined the forum, Dr. Wong?
So thank you very much for the kind invitation for the organizers and having me share some ideas with you on point of care ultrasound. It's something that I'm very passionate about, something that we do, and I'm sure it's something that you do as well in your hospitals, in your department. And what I tried to do is in this lecture, is to bring together all the different elements of heart, lung, abdominal ultrasound into a bit of a cognitive framework to what do you need to think about when you're managing fluid on the intensive care unit. So I hope it would resonate with you. And if you've got any questions, please feel free to put them on the chat, and I look forward to our discussion later.
Thank you. Thank you. So with more than 100 participants crossing today, let's start the session. So I just play the recorded video. Thank you.
Hello, everyone. My name is Dr. Adrian Wong. I'm a consultant in intensive care medicine and anesthesia at King's College Hospital in London. Thank you very much for the organizers for this kind invitation to discuss and share with you some ideas on a topic I'm very passionate about, and that is ultrasound to guide fluid therapy. A couple of disclosures of interest. I work in the National Health Service in the UK, but I also do some work for a couple of these organizations, including the ESICM and the International Fluid Academy. My research interest is around fluid and ultrasound, as you may have guessed, and I'm doing a PhD at King's College Hospital, London. Okay, the key message: fluids are drugs. We all know this, and like all drugs, they've got their indications, contraindications, side effects, so on and so forth. But it's almost too easy at times to prescribe and administer fluids, especially on the intensive care unit. of you may have heard of this already. This is the different phases of fluid management, or the roles: resuscitation, optimization, stabilization, and evacuation. Considerable work has been put into this by Professor Manuel Brain and colleagues, and I quite like this compartmental model because it makes us think a bit harder about how we deal with fluid challenges on the intensive care unit. And I have to say, as a community, critical care has often focused on the resuscitation optimization phase, i.e. giving fluids, whereas the stabilization, evacuation, de-resuscitation phases, the latter stages, have only recently gained more prominence. Then extend the four-compartment model or four phases model of fluid therapy and think about the type of monitors you could use during the phases. You could come up with a table such as this one, published by Eric Holst and colleagues. And as you can see, echo, Doppler, ultrasound is actually useful across the four phases. And I hope to convince you of this during this talk and indeed later on during the discussion. So when you take the four phases: resuscitation, optimization, stabilization, and evacuation, on one side, you can convert that into some more traditional style of questions: when to start IV fluids, when to stop fluid administration, when to start fluid removal, and finally, when to stop fluid removal. However, one of the things that have been emerging in the literature and research of critical care fluid management is the concept of congestion. We'll talk about this later on, but there are parallel questions you can ask. So you've heard the first four. The parallels could be when congestion is absent, before congestion emerges, as early as congestion emerges, and when congestion is controlled. So managing congestion is a universal priority at all times. Ultrasound helps you do this. Now, as you can see, there is a variety of different types of ultrasound machines available in the market, from traditional big radiology level like ones to more handheld devices. And indeed, it's almost ubiquitous in critical care practice these days. Just to summarize then in this slide, and I hope to show you some of these concepts, you can use ultrasound to do so many different things. You could use it to assess the right ventricle, venous assessment. You could use it to look at the lungs. You can look at the cardiac output, so on and so forth. Minimalist toolkit could be something such as this. You've got the ultrasound machine there. You could look at the right ventricle for its size and function. You could look at the left ventricle for the cardiac output. You can look at the left atrium for the filling pressure. You can look at the lungs, something called B lines, to look at lung congestions. And you can look at the veins, something perhaps some of you may have heard of, the Vexer score. And we're going to go through that later on in this talk. Let's start with giving fluids, the bit that's easy to do, almost too easy to do, like I said. If you take a step back and ask yourself, why are you giving fluids? What is the indication of fluid therapy for this particular patient? Now, most of the time, what we're trying to do when we're giving fluids is to improve stroke volume in the preload responsive patients, and therefore improve cardiac output and improve organ perfusion, oxygen delivery to the vital organs. That's what you're trying to do when you are administering fluid. We will remember such as this one, the Frank-Starling curve, when the idea is that when you give a fluid challenge, you increase the preload in the preload responsive patient and you improve the cardiac output. We've often talked about fluid responsiveness when we're dealing with fluid therapy management strategies. At this point, I would like to introduce the concept of fluid tolerance. And this is one of the papers I would recommend. It's a very nice short paper by Eduardo Cartan, who's from Chile, and a couple of other names that you might recognize there. In it, it talks about the various, or rather the balance between fluid responsiveness and fluid tolerance, and the 4 different scenarios that might govern the way they interact with each other. And I highly, highly recommend this paper. Let's talk about ultrasound now, finally. Let's talk about what you can use ultrasound to see, to assess, and we're going to start with the heart. We take a step back and look at shock. You can probably come up with the various classical types of shocks: hypovolemia, obstruction, cardiogenic, so on and so forth. But I put this slide in here to illustrate the point that they do overlap. So you can have a patient who is septic, who has got distributive shock, but also cardiogenic shock because of septic cardiomyopathy. The standard geography is parasynostosis, apical cardiac. I mean this and I think it would be as a scan for biologically in the echo such as it that it be mostly in the impact is the feed like the out fusion the size these information hiding give fluid or not. What not looks in a slide these so in parallel long a chamber how to the very poor heart and the in so you could what oh look number values are the well the jump out and moves short of definitions again: fluid stability of cardiac output to by 10 to 15% following an admission of 250 of fluid over a specific. Or to judge fluid responsiveness, you have markers, but also dynamic markers. I have to say we've moved away from static markers more onto dynamic. So what do you in your intensive care unit later on? When it comes to sound development, to grow is most of the foot track in an apical image such as trace VTR. If you drove for, you will need the parameter of the track.
I think some audio issue. Just give us 1 minute. We'll be sorting it out. Thank you.
And a key message now, just because you're fluid responsive doesn't mean you need fluids. So that's about so perhaps it's not a good idea to give. Oh, I'm hoping that we decide.
Can we have a live session? Dr. Wang, can we request? There's a lot of delegates are requesting if we can have a live.
Yeah, you've clearly not tested your connection. This is exactly why I've sent it to you in advance to avoid this. But if you stop sharing the screen, I will just switch to my screen and do it live.
Yeah, that's better.
Yeah.
Please, it's frustrating for everyone. Okay.
Really.
Okay. What I'm going to do is around the questioning the heart phase. Is that okay, everyone?
Yeah.
Yes.
Yes, yes.
Can you see my screen? Because once on this here, I can't hear you, can't see the people asking questions.
Yes, sir. Yes,
okay,
visible.
so let's talk about, so you've heard why. Let's talk about the heart first, okay? So one of the things I like about cardiac ultrasound is that when we deal with things such as shock, which is a core area of what we deal with on the intensive care unit, these are shock overlaps. So you know when in exams and people ask you, these are different classifications of shock, but the point I make from this is that they overlap. So if you are septic and are shocked, the shock could be because of distributive, so vasodilatory. Equally, the shock could be cardiogenic because of things such as cardiac septic cardiomyopathy. And this series of images just shows the standard echo views that I'm sure you're all familiar with. The parasternal long axis, parasternal short axis, the apical four-chamber, and the subcostal four-chamber view. If you look at intensive care ultrasound, cardiac ultrasound programs, they generally speaking differ from cardiology echo ultrasound programs by being the fact that they're focused, i.e., we are intensivists. We are not cardiologists. We are not echographers, if you will. So just by taking a good look at simple 2D images, you actually gain a lot of information. How big the chambers are, how well the ventricles function, how big the atria is, what the valves look like. You can measure things, all without color. And it's important to discuss the issue around color and training, because if you don't know what you're doing, you are potentially going to cause harm as well, or you are going to cause harm. So that's just cardiac ultrasound. So I've shown you what normal looks like. Those are series of normal. Have a look at these hearts. These is a parasternal long axis view and an apical four-chamber view, and it doesn't take a cardiologist nor any special measures techniques to look at these images and go, these are not good hearts. These are hearts where the LV and the RV are not functioning very well. So if you're thinking about giving fluids to these patients, perhaps you should do it very cautiously, or indeed not. Look at this heart. So apical four-chamber, again, nothing special. I haven't used any color. I haven't used any Doppler techniques. You can see that the chambers are dilated, and you can see from a functional perspective, it doesn't contract very well. So again, in this patient, perhaps giving fluid should be done with the utmost of caution. This one here, parasternal short axis view, papillary muscle level, which I'm sure you're familiar with. Again, nothing fancy, an unhappy left ventricle. This one here is very interesting, and this is a real life case that we were dealing with. a couple of years back. And essentially, this was a patient that presented unwell, fevers, cough, sore throat, productive of green sputum. He was hypotensive, and the thought was he was in septic shock. Classically, he was given fluid, and he was still unresponsive to the fluid challenges that were administered. We put an ultrasound probe on, and this is what we saw. So clearly, it can change diagnosis and treatment management. Onto fluid responsiveness now. So this is the classical definition of fluid responsiveness, the ability of the cardiac output to increase by 10 to 15% after an administration of a small volume of intravenous fluid. So classically 4 mils per kilo, which translates to about 250 mils in the average 70 kilogram male. There are lots of different ways you could judge for fluid responsiveness, and you can divide them into static and dynamic markers. I think it's fair to say that most of us now have tended to move away from static markers and onto more dynamic markers. You'll recognize the pulse pressure variation, stroke volume variation. The IVC collapsibility index, I'm personally not a fan of, and we can discuss that later. The passive leg raise, which is becoming increasingly popular because it's of its sheer simplicity, and also mini fluid challenges. So instead of 250 mils, you can give 100 mils. But when it comes to ultrasound and particular echocardiography, the tool that I normally use is the velocity time integral. So transthoracic velocity time integral there. And this is how you do it. So you need an apical 5-chamber view. You put your pulse wave Doppler in the outflow track, and you get a VTI measurement. Anything above 15 is generally good. You can convert the VTI into a stroke volume, provided you know what the diameter of that outflow track is. And generally speaking, most of us would measure it in the parasternal long axis view. I have to admit, again, in my personal practice, I don't tend to worry so much about stroke volume. I prefer to use the VTI. And again, we can discuss that later in the panel discussion. This is something quite clever. I thought I'd just show it for the sake of interest. This is some clever AI software done by GE in particular. So if you get an apical 5-chamber view, the machine, the software will pick out the VTI, the LV VO2 track, and indeed it will measure the VTI for you automatically. Trend is more important. So as you give fluid back challenges, you play around with the vasopressor, inotropes, the trend is more important than the absolute numbers, in my personal opinion. So that's there, just for the sake of interest. Another take-home message, just because you are fluid responsive doesn't mean you need fluids. And I think the issue I have with a lot of clinical trials and colleagues' opinion about fluid responsiveness, and certainly the message that seems to come out, is fluid responsiveness equals give fluid. That is not the case. Go back, and I highly recommend that article by Eduardo Catan that I showed you earlier, which talks about fluid responsiveness, because I will wager a good amount of money now that if we were to test all of you listening here, almost all of you, I'm sure, would be fluid responsive. It doesn't mean you need intravenous fluids, though. They're not quite the same thing. So that's about giving fluids. Let's talk about things of how ultrasound can help you make the decision to stop giving fluids. I'm hoping that images such as this are becoming increasingly less common, but unfortunately, I think if you walk around intensive care units around the world, you will still find patients with this degree of edema on them, especially if they are on the intensive care unit for a meaningful period of time. And yet we also know that too much fluid, especially after 48 hours of the intensive care unit, is associated with poorer outcomes. And that's increased mortality, but increased morbidity as well. And these are just a selection of articles to illustrate that very, very important point. Again, just as a reminder, these are the hearts that we saw earlier. This is normal, simple, standard views. This is the IVC. And in general, when we look at the IVC, we look at two things. the absolute diameter, so how big, how fat, and how chunky it is. And the other thing that we do is to see how much the size varies with the changes in respiration, so changes in intrathoracic pressure. And in the simplicity side of things, if you've got a small IVC and it's collapsing, then that is a sign that the patient will probably be fluid responsive. Now I'm going to introduce you to lung ultrasound, which is my personal favorite ultrasound modality, if I'm allowed to say that. This is what a normal lung ultrasound looks like. You can see here the rib shadow here, the rib shadow here, and that first bright line just deep to the rib shadow is the pleural line. So parietal and visceral pleura sliding it against each other with a ant marching sign, some people call it. You can see there is either horizontal lines, those are A lines, and every now and then in this corner here, you can see a vertical line, and that's a B line. In the chat, if you do lung ultrasound, do you mind sharing whether you do or don't? It's, like I said, my favorite modality when it comes to ultrasound. Okay, so that's normal. And as you can see here, these two images of lungs are very, very different. If you didn't know what you were looking at, you would describe it as there are much more vertical lines compared to what I've shown you earlier. So these vertical lines, I said they were B lines. In normal healthy individuals, you're allowed 2 B lines per rib space. And clearly here, there are definitely more than 2 B lines. In the right clinical context, B lines are synonymous with wet lungs. So in the right context, these are lungs that are in pulmonary edema. Point of note that you can also see multiple B lines in fibrotic lungs as well. So history, examination are still very important. You shouldn't really interpret ultrasound without any clinical context. These are again lung ultrasounds, and in these two images, you can see a pleural effusion. Very easy to spot, very easy to do. And if you're going to drain it, it makes draining that effusion much, much safer because you can see the needle, you can see the lung, you can see where you need to go, you can see where you don't want to go. Sensitivity, specificity of lung ultrasound far superior compared to plain chest radiograph, and certainly logistically much less challenging than taking a patient to a CT scanner. I put this here because the title of this talk is point of care ultrasound, not lung ultrasound, not heart ultrasound or echocardiography. And that's the power of ultrasound. We as critical care physicians look at the physiology of the whole body and how they interact with each other. So with ultrasound, you can assess the heart, you can assess the lung together, and we can show you some other things to help you make decision of what to do with these patients. I picked an example of a point of care algorithm or a guideline. This one comes from Canada, and it talks about, on the left-hand side of the screen, it talks about what are the signs on ultrasound to give fluids. But I picked this one out because I quite like the fact that they've also talked about signs that make you think, perhaps I shouldn't be giving fluid, perhaps I should be taking fluid off. So in this case, it includes things such as a non-varying IVC, which is large. It talks about lots and lots of B lines on lung ultrasound. It does talk about some cardiac ultrasound signs, and it says whole crystalloids, maybe even give diuretics. Now, on to the topic that has become of great interest, certainly in the last 5 years or so in mainstream literature, critical care, and that is de-resuscitation. And if we think back to the 4 phases of fluid resuscitation, which I talked about earlier, introduced by Professor Malbrain and colleagues, it's towards the end, it's the E, the evacuation phase, often the phase that is ignored clinically, often the phase that requires the most clinical research at this moment in time. And the real question, I think, is how and when do you de-resuscitate someone? This is a really nice, thought-provoking, simple paper published by Jonathan Silversides, who's based in Belfast. It's published in the Journal of Intensive Care Society 3 years ago now. Highly recommend people. And what they did was they surveyed colleagues working in critical care. They presented them with a couple of scenarios and asked them what they would do when faced with these scenarios, which were themed around too much fluid, deresuscitation, so on and so forth. And the take-home message from that paper is variability. In other words, clinicians differ in what they thought was more important as signs and as strategies to manage too much fluid on the intensive care unit. And this just shows the different ratings of importance of the various different signs often associated with fluid overload. So as you can see, some clinicians put the pulmonary congestion on chest imaging as the most important thing. Some people would put increased weight from the baseline as the most important thing. So it's the variability. The same group then introduced the RADAR 2 trial, which I very much think is a favorite trial of mine. Now, if we take a step back and look at the evidence again, we've all agreed that a positive fluid balance after 48 hours on the intensive care unit is associated with increased mortality and increased morbidity. So, by logical extension, if you take steps to control for or start de-resuscitating them and bring them back to less fluid positivity and indeed neutral balance, you should improve mortality and morbidity. Well, unfortunately, the trials haven't really shown that at all. And one of the reasons why that might be is that most of the randomized controlled trial, or indeed actually they're very, very small single center trials that looked at the strategy have never achieved separation. And what I mean by that, if you've got the control arm and the de-resuscitation arm, they don't achieve enough separation. So your control arm may have a fluid balance of, I don't know, plus 3 liters, but your fluid restriction de-resuscitation treatment arm only achieved maybe 500 ml difference. And that's one of the speculated reasons why there is not a stronger evidence for whether this works or doesn't work. But the RADAR 2 trial is very interesting. So this is the time frame, and essentially it randomizes people to early active de-resuscitation, early conservative fluid management strategies alongside a do what you normally do strategy. And I put this slide here to illustrate what they actually did. So they actively screen people to be fit for de-resuscitation. And these, you can see the criteria is there. I want to show you this last point here. So when the group decided that, right, we're going to de-resuscitate this group of patients, this is what they did. They put in 5 milligrams of indapamide daily, 100 milligrams of spironolactone daily, and then a furosemide infusion to achieve the target fluid balance. Or they could put people on continuous renal replacement therapy to remove the fluid. So very, very aggressive attempts to de-resuscitate these patients. And they're just going one slide back, and they've shown that they can achieve separation. Now, whether it was designed as a feasibility trial, so they've achieved what they wanted to show, the next step is to prove whether it benefits patients or not. So certainly for me, that's one of the things I'll be looking out for. Now, I suspect a lot of you who are practicing ultrasound in your daily practice to help guide fluid management already in your department would have heard of something called the VEXA score. This is the original paper, quantification of systemic congestion with point-of-care ultrasound, development of the venous excess ultrasound grading system, or VEXAS. That's the reference there. It was developed by colleagues in Canada, who are really good friends of mine, who I admire very much. And essentially what it does is to start by give the IVC, and it gives you a series of steps to assess the venous side of the circulation. So those are the criteria there. I've got a very nice infographic from the website POCUS 101. If you're interested in anything point of care ultrasound, POCUS 101 is a very good educational resource, and it's free. So step one is to look at the IVC. If it's dilated, you then proceed to step two, but if it isn't, you actually stop there. So step one, IVC, more than 2 centimeters, you look at the hepatic vein. The hepatic vein will ultimately drain into the IVC. There are 3 hepatic veins there. Our cardiology colleagues actually knew about this for a while, but we've seemed to pick it up from critical care more recently. And in this image here, this is what the normal waveform in the hepatic vein should look like. It should have 2 waves, S and D, below the baseline, i.e. flowing from the hepatic vein into the inferior vena cava. And the principle is this: as you become more congested, your right-sided heart pressure increases, and you lose that classical shape here towards something such as this one, where you get almost pulsatile flow, where there's flow towards the probe, flow away from the probe, so above the baseline and below the baseline. You also then assess the portal vein, and the portal vein is more of a, in inverted commas, a classical vein. So when you look and put a pulse wave Doppler within the vessel itself, you should see a continuous hum, which doesn't really pulsatile. It's not really pulsatile. But as the pressure goes up, it starts becoming more pulsatile. So more congestion, more pulsatile. The last vein you can look at is within the renal parenchyma itself, the renal cortex. And the venous flow is below the baseline, and it is a continuous venous hum. Because the vessels in the kidneys are so small, if you put a small Doppler gate on it, a pulsate Doppler gate on it, you can actually pick up the arterial side as well. So you can see the arterial flow above the baseline and the venous flow below the baseline. As your right heart pressure increases, you lose that continuous flow and it becomes more pulsatile. So you then put this all together and you interpret it as shown here. So grade 0, no congestion, all the way to grade 3, very bad congestion. And I hope I've shown you and illustrated the usefulness of ultrasound. Nothing fancy, very simple examination that I'm sure you're all capable of doing, in fact, if not already doing. But it is just a tool. It doesn't replace clinical examination, clinical history, and indeed, perhaps most importantly, appropriate training to do it properly. Because if you get it wrong, you are in danger of causing harm to patients as well. So in summary then, we all know that too much fluid is harmful, and yet it's almost too easy to give fluids. It needs to be treated with respect, like a drug, like any other drug. The power of ultrasound, as I hope I've demonstrated here, is that you can look at so many different organs. You can look at the heart, you can look at the lungs, you can look at the vessels, the blood vessels, the IVC. But more and more, we've also looking at other organs, such as the hepatic vein, the portal vein. There's work going on looking at the mesenteric vessels as well. Giving fluid, stop giving fluid are relatively simple. The bit that I think we have a knowledge gap in the intensive care unit is the latter phases, the deresuscitation phase. Could we be doing it more consistently? Could we be doing it more cleverly? So just to shout out to make sure that what I'm talking about is well within your skill set. This is the basic ultrasound competencies published for the ESICM there. If you're interested in more advanced echocardiography, I highly recommend this website, not because Richard Fisher is a great friend and colleague of mine, but it honestly is one of the best videos there. It's very detailed though. So as you can see from that thing, most of the lectures are almost half an hour long, but I would argue that the quality is second to none. And finally, if you've got any questions, we're obviously going to have a quick panel discussion now. I'll try and answer your questions as best I can. But if you want to reach out for fellowships, collaborations, those are my email contact details. And with that, I thank you very much. I apologize for the technical issues, but I hope we've managed to cover that now. Thank you.
Thank you, Dr. Wong. Thank you for the very elaborative and illustrative lecture. So before we go for the panel discussion, so let me first introduce Dr. Sagun. So Dr. Segun has already joined, I feel. So, Dr. Segun is basically newly appointed intensive care consultant at St. Bartholomew Hospital, and he is one of your very close aid, I suppose. And we are fortunate to have him here in this panel discussion. He has also very special interest in the extracorporeal therapies and ultrasound guided different maneuvers and point of care ultrasound along with you. And he is also a very good clinician well-being, and he is also trained in this point of care ultrasound with his special interest is this online education series. So today we have two eminent good one, I can say the speaker, Dr. Wong, and another panelist, Dr. Segun. And I request all the delegates to put the questions, and we're going to take one by one. So before we take the questions, so my one question to you. So like many of the centers, we use the ultrasound. So what do you think is the learning curve for this such kind of procedures, and how a new trainee should get trained? What are the resources for him?
Oh, this is a massive topic, but very, very important one, because I'm sure we all agree if you're going to do ultrasound, you've got to do it properly. If you look at the various competency frameworks out there for critical care ultrasound, they are very similar, and they quote numbers for focus scans for between 30 to 50 that you need to do in order to get competent. So generally speaking, about 50 scans for focus echocardiography and about 30 scans for lung ultrasound. I think the key point that is a consistent feature of all these different competencies and training frameworks is that you need to be mentored by someone who is there to support your development. So I know, there are lots of courses out there. There are lots of YouTube videos out there that are free and easily accessible. The problem is that you need to practice on real patients. So when I teach my fellows, I separate this out into image acquisition, image interpretation, and then translate that into a clinical picture that you're dealing with. And they are not necessarily the same thing. So you go through the phases, and that's what I tend to remind my new fellows when they are learning. Get good at getting images first, interpret the image. The most difficult bit, which requires the mentorship and expert help, is now you've got the image, how are you going to integrate it into your clinical practice?
Right.
Hello. Yeah. Nanda, you want to ask?
Yeah.
So my question to Dr. Wang and Mr. Segun, thank you very much for this wonderful deliberation and lot of insights about, even though they look like flu responsible, probably they may not be responsive. So this is a great challenge, and there are a lot of myths behind that. So a lot of occasions we see like patients are cardiogenic shock, they are on vasopressors, and there is always an argument between the cardiologist and the intensivist about fluid therapy. And probably, we end up giving less fluid to these patients. How do we assess? I know there are various parameters, clinical parameters, laboratory parameters, and these imaging modalities are also very useful to assess. But what will be the best tool to help you guide yourself as far as fluid therapy is concerned? I know that even cardiogenic shock patients whose lungs are completely wet, they have a lot of B lines, but they may be fluid responsive. How do we, I mean, there is only an option of fluid challenge. but there is a debate. I mean, there is an argument, and then probably being intensivist, we go on back foot and probably don't give fluids in these patients. But even these cardiogenic shock patients also are fluid responsive. How do we, what is the relevance, and how do we assess with the 2D echo that this patient is fluid responsive and we end up giving fluids? My question is to both of you. Thank you. I'm Dr. Akrish.
I know what I'm going to say. Sagan, do you want to go? Do you want to answer this? And then I'll go chip in and fill in the gaps.
I suspect Adrian and I will be on the same page when we say that the first thing is fluid responsiveness actually the real right question to ask in the first place? So what you're trying to do is you're trying to reverse shock. And the way I think about shock is essentially you've got filling state, cardiac power, and systemic vascular resistance. And you're trying to manipulate those three parameters in order to get not even the best cardiac output, because this is the whole idea, pushing people to the absolute top of their Starling curve to get the absolute maximum stroke volume that you can get is probably deleterious, because you'll be at a point where you're harmed, where you're pushing people to the point where the harm is potentially going to outweigh the benefit. What you want is adequate cardiac output and adequate stroke volume. So in that sense, if your stroke volume is adequate, I don't care about fluid responsiveness anymore, because you're achieving your hemodynamic targets and you're perfusing. So eliminating fluid responsiveness in my mind it's looking for fluid responsiveness as the thing to treat for your shock is probably not the right thing to do. You have to go right back to initially, the first thing is, what is the diagnosis? So you've got cardiogenic shock. Why are they in cardiogenic shock? Is this a myocardial infarction? Is this myocarditis? Is this a pulmonary embolus? Is this an aortic dissection? You've got to think through that. And then based on that, you can then have a look and try and work out what your filling state is, what your cardiac power is, and what your systemic vascular resistance is. And then you pick your tool, whether that's going to be fluids, vasoactive agents, or mechanical support, to try and get you to the best position in terms of perfusion as you can. So what we have, we're coming away from this paradigm, and we had this paradigm in the 90s and 2000s where we would hunt down fluid responsiveness and ruthlessly eliminate it and make sure that the patient had no pulse pressure variation or stroke volume variation. And that's potentially harmful. It also results, you have situations such as some forms of cardiogenic shock where fluid responsiveness is actually a false positive. Classically, people with right ventricular problems are a very big cohort for this. So they're giving them fluids when they're fluid responsive would actually cause harm. So that would be my response. My response would be go right back to the history, what the diagnosis is. Second of all, decide and work out, perform some hemodynamic profiling and work out where the patient is. Then decide whether or not fluids are really the therapy, and pushing the stroke volume up is really the therapy that's going to move you away from a position of dangerous shock to a position of adequate perfusion. And then titrate your fluids in carefully to an endpoint. And fluid responsiveness or stroke volume variation or pulse power variation is probably not the endpoint you're looking for. You're looking for perfusion.
Right, and 30% of the cardiogenic shock patients are fluid responsive. Actually, so it doesn't mean that if the patient is in cardiogenic shock, he will not receive fluid or he will not get better with the fluids. So what is your
50% of normal people are fluid responsive?
Yes. What is your take, Dr. Wong, in this?
What I posted a couple of chats. I posted a link to the fluid tolerance paper on the chat itself. So please, it's very short. It's got very nice images in it. And I think I share Sagan's views that we need to move away from fluid responsiveness. What is the diagnosis first? Everything that we do has harm associated with it. And the problem, I think, certainly from my perspective, is that people seem to think fluid responsiveness equals give fluid. And that's not true. There is harm associated with it. So you could have someone who's fluid responsive because, on passive leg raise and what have you. But if you see large pleural effusions already, you see a bit of B-lines already, the balance, what's the risk? What's the potential benefits of this? And it's eloquently summarized in the Hatton paper. So highly recommend reading. So in my practice, I tend to be quite fluid conservative. And I try to encourage my residents to do passive leg raise, minute fluid challenge, give it, see what happens, and then reassess. So that's my view.
Yeah. And there is a very interesting question, like how do you put this invasive hemodynamic monitors in comparison to the POCUS? So how sensitive the POCUS is?
So it depends on the monitor. So what hemodynamic monitor you have, and perhaps this question, it really depends on the scanner, the operator. So I am not, I don't know, Professor De Backer, who can scan TOE everyone. I try my best, but I'm not going to be him. I'm not Xavier Monet. I am not Jean-Louis Thibault. And looking at the list, Jean-Louis isn't here, so that's okay. So the other problem with comparing hemodynamic monitors and point-of-care ultrasound is in the name itself, point-of-care ultrasound at that point. Whereas in hemodynamic monitors, they generally speaking are continuous. So you put in a PICO line, a LITCO line, or something like that, or PA catheter if you do. They are continuous, which essentially means that you don't need to have one person standing there with an ultrasound probe 24 hours a day, 7 days a week. What I tend to do, so in my department, as an illustration, we use PICO as our cardiac output monitor of choice. So when we have a sick patient in, we put a PICO line in, and I get myself or my residents to do a whole body assessment. We then calibrate the numbers, what I see on PICO, what I see on lung ultrasound. It's just another piece of information, which we then integrate into the clinical picture and then come to a decision. But don't forget, your hemodynamic monitor is continuous. Whereas point-of-care ultrasound, you need someone who's trained to do it, who's there. And don't forget, there is going to be some degree of inter-observer variability and performance. So I can say for sure, Sagan scans much, much better than I can. So because of that, the results he gets might be different from mine, just to illustrate that point.
So both are complementary to each other. I feel it's the operator and it's the person who is doing. He should able to interpret and he should able to find out the result out of it. Actually, he should able to interpret the result out of it. That's what is more important. So as per you. And what is your take on extravascular lung water, Dr. Sex?
I think it's an interesting research tool. I think it's useful it's potentially useful as a fluid stop point. I mean, really, we're talking about both derived extravascular lung water using the PICO equation and then comparing it to lung ultrasound. So first of all, I tend to be very suspicious of any parameter that goes through lots of calculations to derive it. But nonetheless, extravascular lung water has shown correlation with adverse outcomes. And lung ultrasound, B lines on lung ultrasound have actually showed decent correlation with increased extravascular lung water on PICO. The challenge here for me, again, increased extravascular lung water is not a diagnosis. I don't treat people with increased extravascular lung water. I treat people with sepsis, with pulmonary edema, with COVID and viral pneumonicities, et cetera, et cetera, et cetera. So whilst that's a nice number to have, it's not the point. And reducing extravascular lung water as a target is not necessarily it's not necessarily the point. It can be a useful marker of decongestion in some patients. And there are, I'm sure some of the readers, people who are interested in this may have read the Pavetta study, which looked at using lung ultrasound in heart failure in an emergency department. And there've been a couple of recent studies looking at titrating therapies, titrating diuretic therapy to lung ultrasound, essentially, and using extravascular lung water as a guide for therapy. You get shorter day, you get an increased resolution in B lines. So you give more diuretics and your B lines go away faster, but you don't actually improve any of the patient oriented outcomes. So it's a nice marker. It's nice to have. It's nice to look at. It's nice to teach people, but it's not the core of my treatment. I treat patients.
But do you routinely monitor the extravascular lung water in your unit?
So I don't. So in my unit, we actually tend to use PA catheters rather than PICO. We use PICO occasionally, partly because I work in a big cardiac unit and with a lot of cardiogenic shock. So first of all, for the most part, almost everybody in my unit turns up with increased extravascular lung water by definition. I used to count B lines at one point. I've stopped bothering because it doesn't actually make a difference to what I do. Once if they've got evidence of congestion, I'm going to decongest them, and I don't need to quantify the decongestion on a daily basis to know that the patient's getting better. I just look at the patient.
Right. So, so another very important questions, like I just want to highlight this point by Dr. Wong, this article which he has put in this group. So, like regarding the mini fluid challenge. So every time this mini fluid challenge is important, or what do you think? We should go with our routine fluid challenge test, because somewhere Dr. Abhijit has put like how 100 ml fluid challenge can make a difference in cardiac output in an adult. So what is your view regarding the fluid challenge test?
If you look at the evidence in that, is what I posted in the chat is basically a review article done by some of the biggest researchers in fluid challenges, cardiac output parameters, and I respectfully disagree that if you can't see it, you can see it. You can see it. And the way I would tend to advise people to use it is don't use it as your default volume for fluid challenges. If you read the literature around 100 ml fluid challenges, the minute fluid challenges, it's for people who you are worried about, that you already think is a high risk of pushing over the edge, if you will. Okay, so these are reserved for people who you look at, they've got a history of ischemic heart disease, of left ventricular failure, right ventricular failure, whatever it is. Instead of going for 4 mils per kilo, which has traditionally been thought of as the volume of choice for a fluid challenge, go small, because then you can see the increment slowly before you push them off the edge. So I don't use mini fluid challenges for most of the patients. I reserve it for ones that I'm more worried about and I'm not sure how fluid responsive they're going to be. Because generally speaking, these are the patients that you look at them from the end of the bed, you've already taken a good history, you've already examined them, and even before you put the echo probe on, your suspicion is that this guy's heart is not going to do well.
Yeah, and while doing this passive leg rising test, so how do you exactly perform the VTI? Because if you want to measure the VTI, because yeah.
So I think it's a funny point, but what Xavier meant by not touching the patient is that some people think of passive leg raise as they get the medical students to put the legs up for the patient, okay? Or the nurses or thing. That's what Xavier doesn't want to happen. It doesn't mean you can't echo them, okay? So it's not that. In fact, he uses the VTI as an outcome measure for the passive leg raise. The way it's described is that you get the patient on a bed and you tilt the bed rather than lift the legs up, which is what I think a lot of people conceptually think is the passive leg raise. They get the medical students up there to put the legs up like that, and it's not what Xavier and Jean-Louis would advocate. You still can put the probe on the patient to do the VTI. That's still possible. I think the other explanation for why that is our patients who have been on intensive care units, they might have joint problems, they might have all sorts of different problems. And when you move the leg like that, you might cause pain, you might wake them up. The sympathetic response to all of this changes the heart rate, the systemic vascular resistance, just by the fact that you've lifted the leg and effectively caused a bit of pain and a bit of stimuli. So by moving the bed, you minimize that component as the reason for the change.
Correct.
Wang, yeah, there is one more question. I mean, how do we assess fluid challenge in pregnant patients? This is really difficult, question probably. I don't know how you take it. Probably because in pregnant patients, the lungs are atelectatic, and the lungs are probably weak as well. And monitoring 2D echo, the preloads are compromised, afterloads are also different. There is a different stress and strain on the heart as well. So how do we corroborate your findings, and how do you do the challenge in pregnant patients, especially the later part of pregnancy? Yeah.
So, okay. So what's interesting is that I've literally, yes, 2 days ago, was involved in a talk with a obstetrician who's based in Johannesburg, South Africa, who runs a maternity critical care. And what he describes, and in terms of how he goes about measuring fluid responsiveness, is essentially what we've been talking about. The technique is no different, but you have to factor in the difference in physiology. So he doesn't think it's possible to do the passive leg raise in a pregnant woman, at least in a traditional sense. I will put the link on the chat later on when I can find it in my email. But he's published a paper where what he essentially did was to look at how moving the gravid uterus and displacing, whether compressing the IVC and freeing the IVC, makes a difference in terms of their VTI. And it does. So in a way, it's an evolution of the fluid challenge, if you will, by using the gravid uterus as your stop go, if you will. What's also interesting is that he says that in this group of patient population, because as pregnancy develops, the breast tissue also develops, which makes that the apical 5-chamber view is much more difficult. He actually recommends the suprasternal approach to look at flow in the descending aorta. It's actually very, very clever and conceptually makes sense. Fortunately, in UK, certainly in my hospital, we don't see a lot of these pregnant patients coming to our ICU. And we're very fortunate because of that.
Yeah, and the same, another funny question is there, like a patient who has undergone a above knee amputation. So how much is the validity of this passive leg rising test? Is in that condition?
Sir, this question was asked in one exam, in a practical exam. That's why it must have been put over there.
Okay. So, Dr. Seix.
The simple answer is the passive leg raise has clearly not been validated in this population. But the more complex answer is that if you still wanted to perform a fluid challenge, the principles of the passive leg raise are performing a fluid challenge without giving any fluid. And so all you need to do is perform some kind of gravitational movement that allows fluid to drain from the lower extremities and increase venous return. So basically stick them flat and tilt the bed and put them in Trendelenburg position, and you'll probably get the same, or you should get a similar effect. But as we said, chasing fluid responsiveness in a patient who's had an above knee amputation who's profoundly hypotensive might not be the best thing to do. You need to think about what the actual diagnosis is and target that. If it's post-amputation and they're still bleeding, then you give them fluid and give them blood. If they're septic, then you give them a little bit of fluid and give them some vasopressors.
Okay.
So we need not forget the gravitational role of a fluid challenge. So the fluid challenge can be given in amputated patients also, provided you make the leg end of the bed a little higher and probably you assess the fluid responsiveness. Yeah, thank you very much for this. You have any question, Dr. Gunadha?
Yeah. Another question, if you don't mind, like what is your idea, or what is the comparison between the blue protocol versus POL protocol, like one of the delegate has asked. So this is something important. I think you should highlight. What is your take-home message in this?
I'll go first. I think I no longer follow protocols, if I'm perfectly honest with you. And I don't teach protocols to my fellows as well. I teach them how to scan. I teach them how to interpret the scan. I teach them how to integrate it into the clinical practice. there is huge amount of overlap between the blues and falls protocols, the Sesame protocol that Liechtenstein comes up with, the Rush protocol. There are loads of overlap. The principles are still the same. You interpret lung ultrasound this way, you interpret heart ultrasound this way, and the difference between the protocol is in the mental construct of how you use the various different images that you have. But the fundamental basis is you still interpret the lung scans this way, you still interpret the heart scan this way. You put them all together as a clinician.
And in patients with these structural problems like lung diseases or patients with the interstitial lung disease or COPD, sometimes it becomes very difficult to assess B lines also in these patients. So, what do you recommend? I mean, there are cardiac filling pressures which may also help you to assess a fluid challenge or fluid responsiveness. But from lung wise, how do we interpret the data in such situations when there is a structural lung problem or any pathology related to the lung? Because it may interfere with the B lines probably. I mean, if there is extensive damage to the lung, or especially in patients with the chest trauma, where they have a lot of lung confusion, and then it becomes really difficult to differentiate between B lines, A lines, and all that. You have any thought process in this situation?
I think that sort of the case that you described, where it could be the trauma, it could be this, it could be that, just highlights the fact that you need to be a doctor first. Get a good history, so on and so forth. Focus, do not treat the scan. Treat the clinician is one of the key take-home message I think we can all agree on. I think in those cases, but as a principle, people, if you take pulmonary edema as an example, okay, lots of researchers, colleagues out there have been trying to differentiate cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. They both have B lines. They both have more than 2 B lines per RIT space. And there have been studies that describe various different variations of these B lines, such as the waterfall sign, so on and so forth. But the principle of these research practice is it depends on your pleura. So classically, if you have cardiogenic pulmonary edema, the problem is not within the lung itself. The problem is the heart causing back pressure and disrupting the lungs, but the lung itself is fine. So in that situation, your pleural line, that first bright line there, is supposed to be smooth, sharp, and very clear and crisp. You can use a pen and draw and trace it out that way. The other side of it is in non-cardiogenic pulmonary edema, say because of lung contusions, because you've been hit by a car or a baseball bat or a cricket bat, as an example, you get, the problem is within the lung itself. So when you look at the pleural line, that is irregular and that is craggy, that is thickened, so on and so forth. So broadly speaking, that's what research colleagues have been looking at. I don't tend to use that, mainly because if you're worried about whether this is cardiogenic or non-cardiogenic, scan the heart. Then you know whether this is likely to be cardiogenic or non-cardiogenic. That's how I tend to approach it.
Thank you very much for this.
So I think we have no more questions in the chat box. So I just want to give one message to all our new budding intensivists who are going to practice ultrasound in the future in the critical care. So one from Dr. Sagun and Dr. Adrian. So
Dr.
so what is
Dr.
your take
Sagun,
home?
your take-home message or any valuable suggestion for the budding intensivist. I mean, when they are handling ultrasound as a tool for fluid responsiveness. So, any final take-home message from your side that I got here, requesting you to give to the delegates.
Adrian, do you want to go first?
Actually, I was going to say, Sagan, you can go first.
Okay, then I'll go first. So I think I'll have 3 take-home messages. Fluids are drugs. You must always remember that every time you stick a bag of fluid up, a fluid challenges is not benign. It is a drug with side effects, and you have to think about it. You have to think very hard about it and think about what you're going to do downstream if it's not the right thing to do. Because if you're given fluid and they didn't need it, that fluid needs to come back somehow. My second thing is fluid responsiveness is actually quite hard to do properly and may not actually be the best thing to look at. You want to think about hemodynamic characterization of your shock, of which things like stroke volume and pulse volume variation and other evidence of what we call fluid responsiveness are a part of. My last thing is think about volume tolerance or volume safety as well as fluid tolerance, because it's not as well as fluid responsiveness, because it's not just, oh, does their stroke volume go up with a bolus of whatever you have? Is this the right thing to do, and will this cause harm? So those are my three take-home messages. Fluids are drugs. Fluid responsiveness is a very tricky concept, and fluid tolerance should be thought about as well.
Thank you, Dr. Wong.
So Sagan has gone down the fluid side of things. So I guess I'll go down the ultrasound side of things then. I think so. My take-home message is that I think ultrasound should be part and parcel of what we do as intensivists. So you need to get trained properly to do it, because if you do it wrong, you have the potential to cause harm as well. The second thing is that I would recommend that people get comfortable scanning all organs and not necessarily just the heart or just the lungs. We are critical care physicians, intensivists. We look after the whole patient. So with ultrasound, get good at scanning the whole system. And I think my final point around ultrasound is that it's there's so much you can do. There's so much you can do. We haven't even touched on splanchnic perfusion that Francesco Corradi has talked about. We haven't looked at ICP and transcranial Dopplers to guide resuscitation targets in shock. The potentials are huge. But just because you can do something doesn't mean you should do it. So you're a clinician first, treat the patient, not the scan. So take home message: 1, get good training, get good at this, get good at scanning whole body. And 3, treat the patient, not the scan.
Thank you. Thank you very much to both of you. I think you have, in a very short summary, you have elaborated everything what is needed for a budding intensive care practitioner. And I would really thanks both of you from our institute and from our critical care department, and we'd like to have more and more such interactive sessions with you and collaborate also with both of you in the future. And hopefully the knowledge will disseminate to all the new practitioners in the critical care medicine. So with this,
Thank you very much.
Thank you. Thank you. So Swapnil, if you're there, can you conclude the session? Okay, so with this, we'd like to conclude the today's session. And again, thank you to both of you. And I announce that today's session is going to be closed. Thank you.
Thank you very much, everyone, for having us. Shout out to Dilshan. We work together in Oxford, who's listening in. It's really nice to hear from him again. So thank you very much. I look forward to other opportunities to talk and discuss ultrasound. Take care. Have a good evening.
Definitely.
Thank you very much.
Thank you very much, sir. Thank you. Bye.
Good night. Good night for now. Thank you very much.